Welcome to the deep dive. Today, we're tackling something absolutely fundamental, the invisible architecture of how medicines work, pharmacokinetics, or PK.
Right, PK.
And we're aiming to go beyond just, textbook definitions. The mission here is really understanding the dynamic science of drug movement, what the body does to the drug. It's the bedrock, really, for safe and effective therapy.
Absolutely. We've pulled together a whole stack of sources, clinical papers, exam-style questions, the works. And the goal for you, listening, isn't just to memorize ADME absorption, distribution, metabolism, excretion.
Yeah, not just a checklist.
Exactly. It's to see how these steps link together, how they dictate whether a drug actually helps or, well, potentially harms. We want those aha moments, not just a data dump.
Okay, let's dive in. The core framework, as you said, ADME, absorption, distribution, metabolism, excretion. Get these, and you get the basic journey. Miss one, and the calculations fall apart.
That's it. So let's tick them off quickly, focusing on the key metrics. Absorption, drug moving from where you give it into the bloodstream. Simple enough. The key number here. Bioavailability, we call it F.
F. Right, and that's the percentage of the dose that actually makes it into the circulation.
Precisely. And for IV drugs, it's easy. F is 100%. It goes straight in.
But oral drugs, it's usually less, sometimes much less.
Yeah, way less sometimes. That big drop, that's mostly first-pass metabolism. The drug gets absorbed from the gut, goes straight to the liver via the portal vein, and the liver enzymes just chew up a chunk of it before it even gets a chance to circulate systemically.
Like propranolol or nitroglycerin.
Textbook examples.
Yeah.
Huge first-pass effect. You need much, much bigger oral doses compared to IV just to get the same amount of active drug into the blood.
Okay, step 2, distribution. Drug leaves the blood, moves into the tissues. How do we measure sort of where it prefers to hang out?
That's the volume of distribution, or VD. Now, VD is a bit weird. It's a theoretical volume. Think of it like this. How much fluid would you need to dissolve the entire dose to get the concentration we see in the plasma?
Okay, so it's not a real physical volume?
Not usually, no. If a drug loves fat tissue, if it's lipophilic, it leaves the plasma and spreads out wide into the body's tissues. It looks like it's dissolved in a huge volume, so it has a high V8. Digoxin is a classic, hides out in muscle.
And the opposite, if it stays in the blood.
Then it has a low VD. This happens if the drug is water-soluble, hydrophilic, or if it binds really tightly to plasma proteins like albumin. It's stuck in the bloodstream, basically. So the concentration in the plasma is high relative to the dose, making VD low.
Got it. Which leads us to metabolism, biotransformation, mostly liver work, right? Changing the drug chemically.
Right. The main goal here is to make the drug easier to get rid of. You generally start with something lipid-soluble, maybe active, and the body needs to convert it into something water-soluble, often inactive so the kidneys can excrete it.
And this happens in phases, phase 1 and phase 2.
Usually, yes. Phase I often involves the cytochrome P450 enzymes, the famous CYP450s. They make small chemical changes like oxidation or reduction, preparing it, really.
And phase 2?
Phase 2 is conjugation. The body sticks a big polar molecule onto the drug or the phase I metabolite. Glucuronide is a common one. This makes it much more water-soluble, like putting a big kick-me-out sign on it for the kidneys.
Which brings us neatly to the final step, excretion, getting rid of it. Usually the kidneys, filtering it into urine.
Primarily kidneys, yes, though biliary excretion happens too. So those 4 steps, ADME, they're not just concepts. They feed directly into all the numbers we need clinically.
Like clearance, VD, which we mentioned, half-life, loading dose, maintenance dose.
Exactly. All those calculations depend on understanding these processes. And the big goal for dosing regimens is often reaching steady-state concentration, CSS. That sweet spot where the rate of drug going in equals the rate going out.
And getting there takes time. There's a rule for that, right?
A fundamental rule. Time to steady state depends only on the drug's half-life. It takes about 4 to 5 half-lives to reach roughly 95% of the steady-state concentration.
So if a drug's half-life, T-half, is, say, 5.5 hours.
Then you're looking at about 4 times 5.5, so 22 hours, to get close to steady state with continuous dosing. 5 half-lives would be about 27.5 hours.
Okay, but hang on. What if someone's critically ill? We can't always wait 22 hours, or maybe 80 hours if the half-life is 20 hours. Can't we just give a huge first dose?
Good question. That's exactly why we use a loading dose,
Yep.
LD. The maintenance dose dictates the level of the steady state, but the loading dose is calculated using the VDUP. It's designed to quickly fill up that theoretical volume of distribution to get the plasma concentration up to the therapeutic level fast, bypassing that 4 to 5 half-life wait.
So it's a clinical shortcut for urgent situations.
Precisely. You get the concentration up quickly with the LD, then keep it there with the MD.
Makes sense. Okay, we've covered the basics, the normal journey. Now let's talk about where things get tricky, even dangerous. The difference between first order and zero order kinetics.
This is crucial. First order is the default for most drugs at therapeutic doses. The body's elimination systems, like those enzymes, are not overwhelmed. They clear a constant fraction or percentage of the drug per unit time.
Meaning if you have more drug in the body, you clear more per hour.
Exactly. The rate of elimination is proportional to the concentration. Double the dose, you double the initial rate of elimination. The half-life is constant. The concentration decay curve is exponential. Predictable.
Okay, that sounds manageable. So what's the deal with zero order? Why is it the exception and why is it dangerous?
Zero order happens when the elimination system gets saturated, completely maxed out. Think of it like a toll booth with only one lane open during rush hour. Doesn't matter how many cars are backed up, only a fixed number can get through per hour.
So the body can only eliminate a constant amount of drug per unit time, regardless of how much is there.
Precisely. Maybe it's 20 milligrams per hour, period. Whether you have 100 milligrams or 1,000 milligrams in your system, it's still just 20 milligrams going out each hour.
Which means the half-life isn't constant anymore.
Right. It changes depending on the concentration.
Yeah.
And the elimination curve becomes linear, not exponential. This loss of predictability is the danger.
And there's a classic mnemonic for the main culprits here, right?
Yep, the high-heeled one you absolutely need to know.
Yeah.
Key A. P for phenytoin, E for ethanol, alcohol, and A for aspirin, specifically at high doses, like in an overdose.
Let's take phenytoin, the anti-seizure drug. Why is the switch from first to zero order so clinically hazardous?
Because the therapeutic window for phenytoin is narrow. Imagine a patient is stable on a dose where the enzymes are just about keeping up, operating near their maximum capacity, Vmax. If you increase the dose, even slightly,
The system gets overwhelmed.
totally, it tips over from first order, where a dose increase leads to a proportional rise in concentration, into zero order. Now, that small dose increase causes a disproportionately large jump in the plasma concentration because the clearance can't increase to match.
And that leads straight to toxicity.
Exactly. Suddenly, the patient develops nystagmus, ataxia, confusion, all because those enzymes hit their limit. It makes dosing PEA drugs incredibly tricky and requires close monitoring.
Okay, so internal system failure, enzyme saturation causes zero order chaos. Let's shift gears to external factors messing with clearance. Drug interactions. We need to look at the two main clearinghouses, the liver and the kidney. They present different kinds of interaction risks, don't they?
They really do. Let's start with the liver. Hepatic clearance, mainly via those phase I CYP450 enzymes, is where the vast majority of drug interactions happen. It's like a busy chemical processing plant where different drugs can interfere with each other's handling.
So let's think about warfarin, the anticoagulant. What happens if you give it with a drug that inhibits the specific CYP450 enzyme that metabolizes it? Say, a macrolide antibiotic or a azole antifungal like fluconazole.
Okay, CYP450 inhibition. The inhibitor slows down the enzyme. So warfarin metabolism slows down, it's not cleared as quickly, its level in the blood goes up and up.
Leading to
Toxicity.
Mhm.
In warfarin's case, the INR shoots up and the patient is at high risk of bleeding. This is a classic dangerous interaction. Fluconazole plus warfarin is a big one. Or think about ciprofloxacin, another inhibitor, given with theophylline levels. Theophylline levels can rise dangerously, risking seizures.
Right, so inhibition, higher drug levels, toxicity risk. What about the opposite? CYP450 induction. Drugs like rifampin, phenytoin, carbamazepine, they speed up the enzymes.
Induction does the reverse. It makes the enzymes work faster, chew at the target drug more quickly. So if our warfarin patient starts taking rifampin, a potent inducer.
Warfarin gets cleared too fast.
Exactly. Warfarin levels drop, the INR falls, and the patient is no longer adequately anticoagulated, putting them at risk of treatment failure in this case, forming a clot. So induction, lower drug levels, risk of the drug not working.
So liver interactions are mostly about messing with the metabolic enzymes, speeding them up or slowing them down. How does the kidney problem differ? Renal clearance.
With renal clearance, the big issue usually isn't one drug messing with another's transport out, although that can happen. The more common problem is the kidney itself not working well. It's about organ function.
You mean like in chronic kidney disease,
No,
CKD, or even just dehydration?
Precisely. If the glomerular filtration rate, the GFR, drops, the kidneys just can't filter the blood effectively. And drugs that rely heavily on the kidney for excretion, drugs that are cleared largely unchanged, they start to pile up.
What's a high-stakes example there?
Aminoglycosides, like gentamicin, are a prime example. They're almost entirely cleared by the kidneys. So if you give standard doses of gentamicin to someone with poor kidney function, maybe undiagnosed CKD,
The drug accumulates rapidly.
very rapidly.
Mm.
And aminoglycosides have specific toxicities. They damage the kidneys, further nephrotoxicity, and can damage hearing and balance ototoxicity. Same goes for drugs like digoxin or lithium, also heavily reliant on renal clearance.
Oh, for these drugs, you absolutely have to adjust the dose based on kidney function. Reduce the maintenance dose or maybe increase the dosing interval.
You must. It's critical dose adjustment based on the patient's physiology, not strictly a drug interaction like with CYP450.
Okay, we've covered getting drugs out normally and how that can fail. But sometimes in an overdose situation, we need to actively force a drug out. Let's talk about that trick, ion trapping.
Ion trapping. It's a neat application of basic chemistry in the renal tubules. The principle is simple. The membranes of the kidney tubule cells are lipid bilayers. Things that are lipid-soluble, uncharged, can diffuse right back across into the blood.
So they get reabsorbed instead of excreted.
Right, but things that are ionized charged, water-soluble, they can't easily cross back. They get trapped in the urine and flushed out.
So the trick is to change the urine pH to make the drug ionized.
Exactly. It depends on whether the drug is a weak acid or a weak base. Let's take a weak acid overdose like aspirin or phenobarbital. How do we make an acid ionized?
You put it in a basic alkaline environment.
Perfect. So we give the patient sodium bicarbonate, or HCO3, intravenously. This makes the urine alkaline. In that alkaline urine, the weak acid molecules donate their proton, become negatively charged, ionized, and boom, they're trapped in the tubule, ready for excretion. It significantly speeds up clearance.
Classic overdose management for salicylate poisoning.
Absolutely. Now, what about an overdose of a weak base, like amphetamines or maybe TCAs, tricyclic antidepressants?
Okay, opposite logic. To ionize a base, you need an acidic environment.
Correct. So theoretically, you could acidify the urine, maybe using ammonium chloride, NH4Cl. In acidic urine, the weak base accepts a proton, becomes positively charged, ionized, and gets trapped.
But you mentioned this isn't done much clinically.
Yeah, acidifying the urine carries risks, like causing systemic acidosis, so it's rarely performed nowadays. But understanding the principle is key. It highlights that charged state dictates renal reabsorption.
And there's a mnemonic for this,
A
right?
simple one. Acid, OUT in alkaline, base, OUT in acid. Helps keep it straight. Change the urine pH to trap the culprit.
Very clever. Okay, last major area. We have to consider patients where the standard PK rules just don't apply or apply differently, special populations. Let's start with perhaps the highest risk, neonates.
Neonatal pharmacology is a minefield. Almost every ADME process is immature. Let's take distribution. Compared to adults, neonates have a much higher percentage of their body weight as water.
Higher total body water. So does that mean a larger volume of distribution for water-soluble drugs?
Counterintuitively, yes. For hydrophilic drugs like, say, aminoglycosides, again, that VEAT is actually larger in neonates. There's more watery space for the drug to distribute into relative to their size.
So they might need a higher dose on a mgp or kg basis initially?
Often, yes, for that initial loading dose, to feel that bigger relative volume and reach the target concentration. But then things get complicated with metabolism and excretion.
Ah, right, metabolism. What's the big deficit there?
Phase 2 glucuronidation is significantly underdeveloped. The key enzyme, UGT, UDP glucuronosyltransferase, is just not working at full capacity yet.
And the classic danger link to that is?
Gray baby syndrome with the antibiotic chloramphenicol. It relies on glucuronidation for clearance. If the baby can't conjugate it, the drug builds up to toxic levels, causing shock, cyanosis, that gray appearance, a tragic historical example of immature PK.
Wow. And there's another issue, too, with protein binding, isn't there? Related to bilirubin.
Yes, absolutely critical. Neonates have lower levels of plasma albumin, the main drug-binding protein. Plus, they often have higher levels of unconjugated bilirubin circulating,
So if you give a drug that binds tightly to albumin,
like sulfonamides or the antibiotic ceftriaxone, these drugs can kick the bilirubin off the albumin binding sites. That newly freed bilirubin is lipid-soluble, crosses the baby's immature blood-brain barrier, and can deposit in the brain.
causing kernicterus, brain damage?
Exactly. Irreversible neurological damage. That's why sulfur drugs and ceftriaxone are generally contraindicated in newborns, especially premature ones. It's all interconnected PK issues.
Such critical differences. Okay, let's shift from newborns back to adults for one final example that links back neatly to metabolism. Drug-induced lupus erythematosus, or DILE.
DILE, right? This is a fascinating condition triggered by certain drugs. The classics are hydralazine, procainamide, isoniazid. Patients develop lupus-like symptoms, often rash, joint pain.
But it's usually milder than true SLE, and it goes away when you stop the drug.
Generally, yes. Less likely to involve major organs like kidneys or the CNS. And crucially, the serological marker often found is the antihistone antibody.
And the underlying reason some people get this reaction, it's a PK issue, isn't it? A metabolic difference.
It is. It ties directly back to phase 2 metabolism, specifically acetylation. Patients who develop DILE are often genetically predisposed to be slow acetylators.
Meaning they have lower activity of the N-acetyltransferase enzyme?
Exactly. So they can't efficiently acetylate and clear these specific drugs or their metabolites. Those reactive metabolites hang around longer, accumulate, and seem to trigger an autoimmune response against histioproteins in the cell nucleus.
So a specific inherited defect in a PK pathway leads directly to this autoimmune syndrome.
It's a perfect example of how individual PK variations can have major clinical outcomes.
This has been incredibly clarifying. We've journeyed from the basic ADME steps and the math of half-lives and steady state
Right.
through the critical danger zone of zero-order kinetics with PEO drugs.
Phenytoin, ethanol, aspirin, yeah.
We contrasted liver-based CYP450 interactions with kidney-based GFR problems.
Two very different mechanisms of trouble.
Looked at the chemistry trick of ion trapping, and finally explored the unique risks in neonates and the metabolic basis of DILE. It really brings together how the body handles drugs and where it can go wrong.
And understanding all this is fundamental. Every time a prescriber chooses a drug, decides on a dose, sets a frequency, thinks about monitoring, it's all applied pharmacokinetics. Knowing these principles, these potential failure points, these interactions, that's essential for safe and effective medicine.
Absolutely. So let's leave our listeners with a thought. We hammered home that phenytoin, ethanol, and high-dose aspirin follow zero-order kinetics because their elimination pathways saturate. This saturation makes them unpredictable, harder to dose safely.
The predictability is lost.
So imagine you're designing a brand new, life-saving drug. Would you want to engineer it, if you could, to follow zero-order kinetics or first-order kinetics? And why would that choice fundamentally dictate how complex and how safe its dosing regimen would ultimately be? Think about what predictability means when a patient's health depends on it.